Um, I see that I stand between you all and lunch, with the title of my talk, I'll try to be as equitable as possible so you can get to your lunches. I was asked to speak on equity in action, cite some examples of the work that we do, and also talk a little bit about how the world should be shaping going forward in terms of a better equity amongst us. Now, I was also told that I should touch a little bit on health disparity. I think this is a topic that everybody is well aware of. I think we have not very long ago come out of COVID, and we saw at global level the kind of inequity that the whole world faced. Forget about just India, I'm actually going to say every single country in the world sort of suffered with the inequity that we saw with the COVID pandemic. Now, just to introduce PATH, we are a team of global innovators working really to eliminate health inequities so communities and people and economies can thrive. We were established in 1977, and the mandate of PATH's establishment was to use technology and partnerships to really sort out, or let's say better the healthcare system delivery and healthcare system design. Today, we are in more than 70 countries. We have presence in more than 70 countries with offices in more than 30 countries. As you can see on the map, even in the form of distribution of our presence across the world, we are quite equitable. So we understand the Latin American continent, we understand a lot of global north, as it's called, or the Western world, or the more developed parts of the world. We have presence in Africa, in many parts of Africa. So we've served many marginalized communities, many underserved communities there. And of course, in the Asia region and the Pacific region also we have presence, and that is only increasing. We have a team of more than 1,500 professionals all over the world. These are proper PATH employees, but if you add field staff, consultants, etc., we're more than 5,000 people on the ground across the world, including various different parts, various different continents. We have touched, theoretically, over 150 million lives every year. But just to give you a sense of one of the programs where we help the government of India create and distribute fortified rice to the population through the public distribution scheme, it reaches more than 750 million people every year. So that's the sort of scale of work that we do. And it hasn't just happened overnight, it has taken multiple decades. As you see, we've been in the game for quite some time. And we handle quite a lot of projects every year. Because of our size and presence all over the world, we are able to manage approximately anywhere between 400 to 500 projects a year, touching on various different aspects of health. Now, talking of public health, how exactly we improve public health, these are some of the areas where I thought it'll be useful for you all to, if you are not aware of what all PATH does, these are some of the areas where we are very, very active. Mental health is currently not on the thing, but we have recently entered in that space as well, and we are quite active. And we've delivered a couple of projects in Myanmar region and working with state governments in India as well to improve the mental health capacity capability in the region. We have worked in the diagnostics space, heavily in the vaccines space, in the therapeutics space, medical devices space, and also in the supply chain and logistics space. So most of the vaccines that are today supplied to the world have a sticker called Vaccine Viability Monitor, which was also something that was designed and invented by PATH. And that sticker really ensures that the vaccine reaching the delivery center is of viable potency and the formulation hasn't gone off. It helps the healthcare system really keep track of whether the vaccine is worth giving or it should be discarded. So that is the kind of innovation that PATH has been involved in. We've worked in many areas, including infectious disease, non-communicable diseases, and we've worked in the prevention, promotion, control, and management of disease as well. Just to give you another example, of our work with the Uttar Pradesh government to sort out the Japanese encephalitis and acute encephalitis syndrome issue. We helped the government introduce a vaccine when there was no yellow fever vaccine present in India. We got one introduced from abroad, and we got that rolled out by designing a proper hotspot-based, surveillance-based methodology so that the most cost-effective rollout of the vaccine was done. But not just that, we also helped the government establish primary healthcare centers within the 10-kilometer radius of every single community that was there being affected by the, by the Japanese encephalitis or acute encephalitis. Those centers were called Encephalitis Treatment Center, and those were part of every single primary healthcare center. So it essentially improved the mortality, morbidity in the population, and also it helped the government really hit their target of meeting the reduction in the referrals to the tertiary care setup from the primary healthcare setup. I think this thing has come up a lot this morning, that the decision making has to sit at the primary healthcare level so that the tertiary or the secondary healthcare levels don't get overwhelmed or sometimes don't get referred to even when the things could have been sorted at primary healthcare level. So that is the kind of work we've been involved in already. So just to also highlight, when we designed our strategy, which is coming to a wrap up this year in 2025, we made sure that the design of our organizational strategy itself was as equitable as possible. We involved more than 400 stakeholders in the discussion, design, and formulation of the strategy, and that included health ministries, industry partners, communities, CSOs, and what have you. So all the NGO partners, everybody was involved across 50 countries in the design of our strategy so that it was as inclusive and as representable as possible for the whole entire world, wherever we operate. And so as part of the strategy development, we came up with a mission. The mission itself of PATH said, advancing health equity through innovation and partnership. So this is really sticking to the DNA of the organization in 1977 when we were formed around use of technology and partnerships to better the health systems. We are sticking to the same mission here, but in terms of strategic priorities for this particular strategy, we came up with 3 different strategic priorities, one being equity in health, inclusive innovation, so making sure that the innovation is not missed. It comes up a lot that primary healthcare centers need that innovation boost so that the challenge of access could be minimized. Improving lives with the science and technology as well. So we've been in the space for quite a long time, understand the community, we understand the inventors, we understand what technologies might or might not be successful, even if they look really fantastic to start with. They may not be viable on the ground when implemented in the community. And then we also brought in another pillar of change strategies in this particular broader strategy of PATH, which was around inclusive innovation, equity and health, respectful partnerships, and community-focused priorities. So essentially making sure that everything that we were doing was checking on all those parameters so that we were being as equitable as possible. And then, of course, in the whole process, using all the learnings that we have gained over the years, all the lessons that we've learned, applying all of those and all our capacities and capabilities to really help the whole ecosystem do better. Just to touch a little bit and cite some examples of how our first strategic priority, for example, preparing for and responding to emerging health threats, we were very heavily involved, let's say, again, using the example of COVID pandemic, when the society was facing inequity at a magnitude that not just India as a country, but the world had never seen before. We were involved at that time to reduce the scale of that inequity. So we helped the government increase the COVID-19 testing capacity by also introducing self-testing kits, which were the rapid antigen or rapid antibody based kits, And also we helped the government expand its oxygen capacity and oxygen distribution capability, which I'm sure you're aware of when the second wave of COVID hit, how everybody was scrambling for oxygen everywhere when the oxygen was, although present in the country, but was not present in adequate amounts in appropriate geographies. Similarly, we have helped on various other issues, for example, malaria, AMR, and growing burden of non-communicable diseases like hypertension, diabetes, cancer, etc. And then also to say that we've been involved in improving the lives with using science and technology. What happens is, in many cases at primary healthcare level, a lot of testing can never happen because the technology doesn't allow that. So we have come up, we've actually partnered with a lot of innovators, a lot of organizations on the ground, and some very early stage but patented technologies to bring those to reality and put them to test in the community practices or in the primary healthcare centers to make sure that the very grassroots level healthcare provider or healthcare systems have these innovations that can really address the problem of inequity or provide the access to those screening, treatment, or management solutions that would otherwise not be available to those ground level stations. In this case, for example, we supported the development of this uterine balloon tamponade, which was an affordable medical device to monitor postpartum hemorrhage and visibly really decide whether the uterus has started contracting again or not without really having any expensive equipment or any expensive technology present in the primary healthcare center. So this is now already on track to save about 170,000 lives by 2030. Then increasing the health system capacity through data and making the systems more resilient. We have a program called Data Use Partnership, where we are helping all the governments around the world to really digitalize their data, or at least capture their data and keep a record of that so that they can make informed decisions going forward, so that when people come the next time, they can, the health system can track what the person came for the previous time. We're doing a similar exercise with the Indian government, as most of you would be aware, as per the digital health mission of India. The microsites project of Government of India is where PATH is helping government establish and expand and train the system in utilization of the digital health technology, and making sure that the digital record keeping and digital record sharing between primary, secondary, and healthcare, tertiary healthcare centers happens seamlessly. Then we also go a step further by really building equity in our program benchmarking. As you would see here, all the new projects that we start at PATH are expected to submit a report within 90 days that check on all the benchmarks that we have drafted to meet the equity guidelines of the organization. And so the change strategies is where this comes into play. The 4 change strategies that I talked about previously of equity in health, community practices, respectful partnerships, inclusive innovation. Every single project that we do, and this is, I'm talking about 500 projects or 4 to 500 projects a year, has to go through a mandatory check of every single benchmarking in this. And each of these change strategies that we implement is actually further divided to guide the committee to make decisions on whether we are actually doing our projects in the most equitable manner, or the projects that we are picking are really sticking to the vision, mission, and the strategic priorities of the organization or not. So essentially making sure that everything has equity and access to the core of its existence and delivery. So in equity in health, for example, every single project would have to focus on, not every single project, but most projects would have to focus on marginalized populations, would have to challenge inequity. So lack of equity is one thing, but challenging inequity is another thing. It has to measure the equity that the project brings. It has to also learn about the equity or the challenges that the equity faces in that particular community or in that particular project setting or geography. Similarly, in terms of community practices, whether it addresses community practices or not, whether it identifies and validates needs and priorities of the community, whether it engages the community or not. We don't want to do projects where we are working in a silo where community gets a product which is fully baked and then we realize that it is not really of use or of absorption by the community or the healthcare practice in the primary healthcare centers. Respectful partnerships is very, very important. Us being an international NGO, we make sure that we shift the power to partners. So at every single stage of our project implementation, we make sure that the decision-making power sits with the local partners that are on the ground. We make sure that the transition of projects happens to partners so that the sustenance is in place. So every single point of our project delivery, we make sure that people on the ground are becoming champions of taking that forward, even when we remove ourselves. So I think we were talking this morning, Dr. Moore was saying that the likes of Gates Foundation and others helping the government and saying that we would do it means that government kind of becomes incompetent going forward or really sort of becomes complacent or not really ready to take that on once the support is withdrawn. Then we also check all our projects, whether they strengthen partner capacity or not. So not just transitioning the project to the partner, but also making sure that their capacity is built in the process and they're also getting something out of it. And then respectful partnerships. So making sure that the representation of regional, national, and all different levels of stakeholders is made sure in the projects that we do. And then inclusive innovation. We make sure that users of the innovation are involved in the co-creation of the innovation. Or let's say, if an idea came through, we will take that to the community, do focus groups, and make sure we take as much input as possible before really baking it into a full-blown technology or full-blown product that would be used for deployment. And then building inclusive innovation skills is also something we train the partners so that once we go, partners can continue following the same kinds of practices that we did. Just to give you an example, a couple of examples of how we measure equity in health. So a 5-member team would rate where exactly the project sits. For example, in this case, people with injectable drug use and prisoners, we were focusing on a particular project and we asked a team of 5 people in the organization to rate this project, and based on that we see whether the project should be recommended to continue or should be redesigned or rethought or recalibrated to meet the core vision and mission, which is essentially to keep the health equity at the core of it. Similarly, on challenging the inequity part as well, we do the same kind of exercise. So again, 5 people would vote where exactly the project sits. We would make a decision whether the project is worthwhile continuing or not, or if it needs a bit of a reframing, and we are not shy in even going back to the donors and pitching them the ideas that making the project slightly different or slightly tailoring the project would really improve the sustenance potential of the project going forward. Then the DEI question is also very, very important to us. Not sure what happens to this now since Trump has come and has totally killed the DEI. And we being a Seattle headquartered organization, we are very actively discussing what exactly should we do. We actually have a whole division of DEI led by an executive director. So we are making sure that we represent DEI. Again, as we were discussing over dinner last night, that DEI is not really going to disappear. It's just that it will be delivered through a different angle or through a different wrapping, if that makes sense. So we make sure that our people, our business practices, and as I went through the programmatic equity benchmarking, we make sure that equity is built and diversity and inclusion is built into every single practice of our organization. We are poised to increase the number of women leaders in Africa and AME region. Just to say, I've actually just joined PATH 6 to 7 months ago, and I noticed that India team in particular is very well balanced in terms of DEI, with about 60% of our staff being women. We want 50-50 gender parity in our executive team leadership by this year, and we are almost there. We want 25% increase in the underrepresented groups in the US. This is something we're trying to calibrate now. And we also want that 90% of our people managers should really have the psychological and inclusive leadership tools so that they can make sure that their teams are aware of the DEI principles and are followed. We aim to increase our overall employee engagement by 15%, 35% of women minority-owned small businesses at PATH as suppliers and consultants. So often what happens is when we come out with a tender or with an RFP, major giants would have very polished programs or very polished applications, and in that process a lot of small businesses and small suppliers would end up losing the RFP. So we've made very different way of assessing all the applications that come to us. Even when I was in my previous organization, which was a funding organization, we used to assess applications very differently. If an application from Canada and Ethiopia was coming in the same pool, you just can't compare those because Canada would almost always end up winning it. So we had a separate track of evaluating applications from the West or the global North, and applications from Africa were only compared to the applications from the African continent. So just to make sure that the equity was there, otherwise the global South would never really become a champion, would never really get a chance to learn and build capacity. Now coming to equity in action, I'll just take you through some of the examples, some of the projects that we're doing where equity is really built into the core of it. As I said, for about 50 years, we have operated with a very human-centered design approach in which we really help the health community shift from prescribing solutions to really co-creating solutions that meet the needs. Our processes help accelerate access and utilization of health interventions by rapid testing and refining of the products on the ground itself. And just to further build into that, in the same process, we also deepen and complement the monitoring and evaluation and learning principles. We also build fantastic partnerships and trustworthy relationships. We also build a better understanding of the market and demand and supply infrastructure, because if there is generally no business case or no user case, it's unlikely to succeed. We evaluate and test solution with a particular context in mind. We don't go in with an innovation and just test it without the context. So if it was being tested in UP, it would have a very different context compared to if it was being tested in Northeast or Arunachal Pradesh or Assam, etc. So it has to be locally adaptable. We define and gain insight into a problem with the community involved in the process. And we have done this in pretty much all the areas that you can think of, just to mention some: in maternal child health, immunization, neonatal health, nutrition, etc. Now, one of the initiatives, other initiatives that we launched recently is called Global South Research Collaborative. Another example of the sort of inequity that exists. So if I was to ask you today, how many of you as partners on the ground or policy folks or CSR organizations work in the infectious disease space? Can you raise hands? Okay, so not very many here, but when I asked this question in a room full of people who were working on biosecurity and global health security, all of those people working heavily in the infectious disease space, and when I asked them this question, okay, how many of you now know about the pandemic accord discussion? Do people know about the pandemic accord here? So if you are from infectious disease space, you would know about the pandemic accord. This came into existence straight after COVID pandemic was declared because the inequity became quite apparent, and WHO and other partners came into discussion and said that if a pandemic was to happen in the future, there should be preset principles on how the vaccines, therapeutics, drugs, medical countermeasures, medical devices, raw materials, etc. would get distributed around the world so that the whole world is a more equitable place. So that is the discussion taking place with 194 member countries sitting at WHO every other month to discuss and negotiate what should be those principles that everybody would have to agree to beforehand so that we are better prepared for the next crisis. So such kinds of discussions people are not really aware of, and these are hugely complex policy pieces that would have a large impact on how Global South really either benefits or suffers during the next crisis. So we launched this platform called Global South Research Collaborative, where we simplify these complex policy pieces and we deliver it in the form of a webinar, and we generate awareness and literacy on those topics so that people in the Global South can start participating on those discussions, because unless you know what those complex policy pieces are, you're not going to be able to contribute to those policy pieces. So this is really the purpose of the collaborative. And in the process, we also try and publish white papers like we have done recently. Just on the 20th of January, we launched a white paper on the simplified series presentation we did on pandemic accord, and people are really benefiting. The launch of this thing itself was attended by 120 people from 16 countries and all 6 different continents around the world, including various government partners, European Commission, US FDA, etc. Were all on board. The other example that I'd like to bring to your notice is a project called Serum, where we are engaging with community for improving the rational use of medicine. It's not as easy as it looks here on the slide, because we don't really know why irrational use of medicine happens. I was talking to some ICMR scientists recently, and they said the policy says that antimicrobials cannot be purchased through pharmacies because they are Schedule H drugs, but they do get purchased. But the issue really here is about behavioral change. But as I was listening to the panelists, behavioral change is the least successful model that can be implemented. So what we're trying to do here is we're first trying to really understand how big is the problem of irrational use of medicine at the ground level. So we are picking a small cohort in Delhi, and we're doing a study using questionnaires to really establish a baseline of why and to what extent are people just going out and buying Schedule H drugs, not just antimicrobials, but also some other Schedule H drugs like NSAIDs, etc. This also means that we are touching on why wrong diagnosis or lack of diagnosis can be the driver. How wrong choice of medicine can really influence the kind of treatment and the kind of journey of the patient, and how wrong administration, error in dosing, or mixture of different drugs, drug entities that are not compatible with each other and then causing issues, etc. As I said, we are talking of engaging community here, engaging with urban residents, healthcare providers, pharmacy providers, community leaders, and young volunteers. Um, the other thing, again, highlighting how innovation can better the equity in the ecosystem, is this innovation of neonatal intuitive feeding technology, or NIFTY cup, that Path was involved in the design of. You'd see some children, either preterm children or malnourished children or children born with a cleft lip, etc., are unable to really have that suck action. So for them, we designed this cup, and we went through a process of multiple iteration for about 5 years, engaging community, engaging device manufacturers, engaging food manufacturers, etc., to come up with this cup, which helps babies of all level of nutrition and babies with cleft lips to suck on this or lap onto dosing of milk at a constant pace. Then also we came up with a self-injectable contraceptive, which is now marketed by Pfizer. So as you see, this is a hugely sensitive issue. A lot of people don't really want to go to a doctor and buy contraceptive or get injected with contraceptives, but they now can actually have this in their home. And one of our beneficiaries said that I will only have child now when I want it. So this self-injectable device really has helped a lot of people in the developing countries, and especially in rural areas where social stigma is huge, to come beyond that stigma and actually use this at their own ease. Then talking of addressing mental health, again, I think this point came up this morning that if you go to a tribal population, they don't really have access to a doctor in about 30 kilometers range, but what they would rather do is go to a Baba or go to a non-traditional practitioner. So what we did here in Rohingya population in Myanmar is we made a bridging course for training some non-traditional practitioners, so they can actually advise and guide and be the helpers to the Rohingya population in Myanmar, population that doesn't really have access to fully trained professionals in the mental health space. And in that, we have delivered this aid to about 23,000 survivors of a cyclone hit community, which really again tells you the value of expanding the services and thinking beyond just the field of medical or healthcare practice when you're delivering healthcare. In terms of strengthening primary healthcare, I think this has been discussed at length. We are working in Satara district, and we are making that a model district for comprehensive delivery of primary healthcare by installing all different kinds of technologies, including AI-based stethoscopes, cervical screening technologies, breast cancer screening technologies, AI-based TB screening methodologies. Everything has been installed in this Satara district, and we are working very closely with the Maharashtra government to make sure that this district can also then be used as a model to test innovations and to test the scale up of various different innovations that can then be utilized elsewhere in the country, and not just in the country, but way beyond the country in other parts of the world as well. Just to highlight, as I mentioned, some of the innovations that we've helped become a reality would be non-invasive breast cancer screening, AI-based stethoscope that can pick minor signals and actually can just give you a signal on your phone in the form of what exactly is it that you need to interpret from the AI stethoscope sound. AI-driven mental health chatbot, AI-based spirometer, which would also again help improve the access of pulmonary testing. And then also in the last mile cold chain solution, because in a lot of remote parts, you can't actually have cold chain delivery of vaccines and many other drugs that would require cold chain to get to those particular communities. So we helped the design of Emvolio, and not just design, but also help them test the technology in the field. Similarly, Cure AI, that many of you would probably be aware of, is being used to screen X-rays for all different kinds of things, including TB, cervical cancer screening, and non-invasive hemoglobin testing services as well. So all these innovations are important for primary healthcare centers to actually become equipped and accessible to people. Otherwise, the kinds of technologies that you need to provide comprehensive primary healthcare would not really be feasible, especially at the scale of where India operates and the number of primary healthcare centers that would have to be equipped with expensive technologies. And then finally, on my last slide, we use digital health and digital technology to really help everything come together, including, as I mentioned, the microsites project of the government, or as I mentioned, the rice fortification project that we're doing. We've built a digital dashboard to help the government track every single step from the quality testing of the fortified rice to the distribution of the fortified rice, reaching the very last consumer that gets access to the rice kernels through the public distribution system. And I think with that, thank you all for your attention. I know lunch is waiting. Thank you.
I was just curious about the device you all have developed for prevention of postpartum hemorrhage. So how does it work? I mean, what is the mechanism?
So contracting, then the balloon will be pressed, and the water level in that bag will go up or down based on that. So based on that, you can see when the uterus would start contracting, then you can actually see that the postpartum hemorrhage can be.
So I think it's maybe a compression-based.
It's mainly a compression-based system, but in the bag you can really monitor what compression.
You mean there's a monitor outside the bag?
No, just the bag itself, just the visibly.
No, the bag goes into the uterus, you said.
No, the balloon is going into the uterus.
The balloon is
going. The bag is visible to the practitioner.
Okay, thank you. And I think that cup is probably, it will prevent aspiration pneumonia. That's the reason for that one with cleft palate and preterm.
Right.
Thank you very much.
Thanks.
Failures. So could you maybe also speak to some of the failures, especially from health equity perspective? So PATH also has had controversies, including in India. So I think part of our mutual learning is perhaps also speaking about where we stumbled, where we failed, all of us have, and what have you learned from that, how you may be taking corrective measures. So if you could speak to some of those examples.
So there are quite a few that we have tested and piloted on the ground and that have not been found as feasible. Vaccines in particular, many of them have gone to phase 3 clinical trials and have really failed. Medical devices, again, at the primary healthcare level, when you realize, sometimes you need reagents treated in a very different way. Sometimes you need very different kind of training or very complex training provided to the primary healthcare staff, which is just not feasible in terms of scaling up. So, but I'm happy to get back to you with concrete examples.
There's a lot of literature in global health now about organizations that work across large geographies. PATH has a very large geography. There are much smaller scale of institutions like us, which have multi-state, and then many other NGOs which have multiple others. So in these instances, the literature is telling us about whom do these organizations remain accountable to. So when you are a small CBO or an NGO, it's very easy to go and ask, okay, you say you're working for us, please work this way or do that. There are these fora. But the further up and up you go, the accountability moves to funders from communities. So it's just a comment. I think all organizations, as we scale and as we become more influential in global health, how do we remain grounded and accountable to people, and what kind of platforms do we give for them to be able to influence our work? So it applies as much to you as to us.
Lot of times what we generally grapple with is, especially with technology, the digital health bit that you said, it's very, very difficult to have an equity lens when we're talking technology. The only technology that appears to be available to everybody is WhatsApp and maybe TikTok now, that's banned, maybe Instagram or something like that. Not so much the useful bit of technology which we talk about in diagnostics or in treatment. So how difficult has it been for you to maintain an equitable access, not so much in terms of your pilot projects. Pilot projects, even Cure AI worked pretty well. But we've been seeing over the past 4 years, for some reason or the other, we're not able to scale up these pilots. So, and that is where inequity persists, especially in terms of digital technology for diagnostics and access. What has been your understanding or experience in that?
So I think system that we've developed for tracking the fortified rice value chain. What happens is when you're trying to bring different kinds of stakeholders on board, whether those are millers or factory owners who have to then feed data into it, you have to make sure that the user interface is as easy as possible. And also different kinds of factories would have different kinds of talent. Some people would have a data entry person in their factory who is more capable of feeding data into a slightly more complex user interface, whereas some factory would have a very lay kind of labor working in that factory. So I think you have to make sure, if you are addressing the problem at a scale or at national level, which in India is a huge scale, you have to make sure that you address every single type of feedback that you get. So, and that takes a number of years to get through, and the level of maturity of these digital user interfaces itself takes time, takes a number of years, and that's been our learning in the digital space in particular, that you have to allow a maturity time, because the feedback sometimes even after a couple of years you see that now it's foolproof. In the third year you'd see something very fundamental that would come up and you'd have to flip the digital technology completely.
It is feasible to what action back you जो भी इक्विपमेंट्स आपने किए हैं उसका सही में यूज़ हो रहा है, कितने लोगों ने वो यूज़ किया है, वो इंटरसेक्शनली यूज़ हो रहा है, वुमेन्स के साथ यूज़ हो रहा है, या वो रिप्लिकेबल है, कैन वी यूज़ इन आवर फील्ड टू?
सो दैट्स डिफरेंट स्टेट गवर्नमेंट्स के साथ भी उस मॉडल की लेसन्स को डिस्कस करते रहें. So that Satara district में जो काम कर रहे हैं, it may not work in Arunachal Pradesh, for example. So we are making a regular bridge of interaction between different governments, telling them कि सतारा में हम ये काम कर रहे हैं, ये lessons हम सीख रहे हैं. Will this work in your setting or will this not work in your setting? And not just the governments, also because हमारी जो field की teams हैं छत्तीसगढ़ में, झारखंड में, बिहार में, अरुणाचल में, असम में, उन सबको भी हम बिठा के we do those focus groups internally at PATH and we tell them कि सतारा में ऐसा हो रहा है, क्या ये असम में applicable है या नहीं है, या इस stage पे if we want to modify something कि हम क्या modification हम कर सकते हैं, so that it becomes a truly nationally scalable. और हमारे केस में we are not just thinking nationally because of being an international organization, we regularly interact with our offices in Latin America, offices in Africa, वियतनाम में हमारा ऑफिस है, तो उनको भी हम वो सारी इनोवेशन रेगुलर बेसिस पे चेक करते रहते हैं, बिकॉज समथिंग वर्किंग इन इंडिया मे नॉट एट ऑल वर्क इन वियतनाम बिकॉज ऑफ कल्चरल डिफरेंसेस. सो यू आर एब्सोल्युटली राइट. सो वो टाइम टू टाइम दैट हैज़ टू हैपन, अदरवाइज द स्केल ऑफ इट और द even if the scalability is established, the deployment of it fails.